Good morning. Let me thank you for taking your time this morning to be with us. 6 months ago, we announced the creation of a Southeast Regional Pilot Acute Stroke System, bringing together the hospitals in 18 counties in Southeast Alabama to implement a system to route patients who were having strokes, acute cerebrovascular events, to the most appropriate hospital so they could get early intervention and definitive care. We modeled that system after work that had been done in the Birmingham region, and we now, 6 months in, have some early results and wanted to share them with you. Our goal is ultimately to take this system statewide. Stroke is in many ways similar to myocardial infarction. In the case, obviously, of a myocardial infarction, time is equivalent to heart muscle survival. In the case of especially occlusive strokes, where a clot blocks a blood vessel in the brain, time is associated with brain survival. So early intervention becomes extremely important in trying to mitigate the complications and the consequences of an acute cerebrovascular event. Stroke is the leading cause of long-term disability in the United States and is the fourth leading cause of death. In fact, on average, someone dies in the United States of stroke every 4 minutes. Over the last 6 months, we've had now 1,260 people entered into the Southeast Stroke System. Of those 1,260 people who have been entered into the system, who have then been referred for intervention, 656 of those individuals were admitted to the hospitals, meaning that we are both identifying people who are having stroke, but we also have a high level of concern, and we're routing people who have symptoms who fortunately are then found not to have strokes. The result of that is we're probably not missing significant numbers of individuals with this system. So that's a positive encouragement. The advantage of early intervention is that stroke, when people present with symptoms of stroke and it's due to a blocked artery, they can be given an agent, a clot buster, that then can return circulation to that section of the brain, preserving brain function. But unfortunately, that doesn't work indefinitely, and so early intervention within the first few minutes to first few hours makes a huge difference in the success. We now have 18 counties in Southeast Alabama who are part of this Southeast Stroke System. 17 hospitals participating, where patients are routed based upon their presentation to the most appropriate hospital who can provide them early intervention. We utilize the same dispatch center, the Alabama Trauma Communication Center in Birmingham, to do the routing for stroke as we do the routing for trauma. We're constantly monitoring this system. We're constantly trying to improve this system. At the end of the day, we believe once we have a little more experience here, we want to take this system statewide so that not only patients in the Birmingham regions and patients in Southeast Alabama will benefit from the impact of a stroke routing system, but statewide, just as our trauma system routes people to the right location for trauma care, we'll be able to route people statewide to the right location for early intervention and stroke care. I'm joined today by most of the people who've made this possible. Dr. Sarah Nafziger, Dr. John Campbell, Dr. Stephen Suggs, Mr. Joe Acker, who runs the Regional Emergency Medical Center in Birmingham and who runs the Trauma Communication Center for us in Birmingham. So let me pause here and give first let me give Dr. Nafziger an opportunity to make some comments.
Thank you very much. First, I'd like to talk a little bit about how patients are entered into our stroke system. First of all, we like for patients to call 911 when they recognize that they're experiencing stroke symptoms, such as unilateral weakness in their body or difficulty speaking. When patients call 911, then they're access to the EMS healthcare system, and our EMS providers are trained to also recognize symptoms of stroke. When that happens, our EMS providers have been trained to enter the patients into the stroke system, and in doing so, they call the Alabama Trauma Communication Center and provide them with information about the patient. The Communication Center then helps the EMS provider identify the closest hospital with the available resources to care for the patient with stroke symptoms. Now, certainly, sometimes patients choose not to call 911 and access the hospital themselves, just go by private auto. And the hospitals in this area are also able to enter patients into the stroke system by calling the communication center themselves. Now, I will turn the program over to Dr. John Campbell, who will speak a little bit more about the system.
Certainly, time is of the essence in beginning treatment. And the quicker that the clotbuster drug, which is the same one we use for heart attacks, the quicker that can be given, the better your outcome's going to be. But the biggest question is, who do you need to give it to? Now, we have a very few neurologists. So it's just impossible to get a neurologist to evaluate in person every patient that has symptoms of a stroke. And so with technology, we now have telemedicine, which is actually fairly simple now with a small video camera and the microphone. Then a neurologist anywhere in the state can examine a patient, because certainly a view of the patient is worth 1,000,000 words of description. And so we can now simply by calling them up, they can pull up all they need is a computer and can look at the patient, examine the patient, make the decision, and then almost any emergency department can give the medication, and then decisions can be made later about where they go. And so this, not only will telemedicine make this system work, probably in the future it's going to be the savior of the small town hospitals, because we're going to see the day that the multi-specialty groups will provide instant patient consultations at any hospital, anytime, night or day, making the patient not have to be transferred to big city hospitals to get the kind of care they could get at home.
Thank you. I would like to speak some toward the hospital's perspective of the stroke system. Stroke is very time sensitive, as they have discussed with you already, and it's important to get patients treated quickly. The system allows patients to get to the hospital as soon as possible. One of the main limiting factors we have is patients identifying that they have a stroke, and so I think it's important to talk about the symptoms. Again, visual loss, one-sided weakness or numbness and tingling, and difficulty walking, dizziness, those kinds of things that are of sudden onset need to be treated as a stroke, and the thing that you need to do is call 911. This system will route you to the closest hospital that will be able to give you the treatment that you need. In the hospital, we've done all we can to streamline the decision-making for giving TPA, so that we want to have a CAT scan immediately available. We want to rule out other medical conditions that can mimic a stroke, but have everything in place so that we can administer the medication. And the beauty of this system is that it's a very unique blending of state-of-the-art medicine, telemedicine, internet connectivity, and communications all working together to effect a good outcome for the patient.
It's an honor to get to follow Dr. Suggs, because if we don't have a champion neurologist, and they're few and far between, Dr. Suggs, then we don't have a system. It's all built around that neurologist that has to make that decision and intervene on the patient's behalf. So what's the real importance to people in the Southeast region at this point, and how well is the system functioning literally on a day-to-day basis? When we compare this system against the only other multi-county, multi-hospital stroke system in existence in the world today, many people believe we're backward in Alabama. We're not on this. We're at the cutting edge. This system in its first 6 months of operation is doing as well as a system that's been in operation for 14 years. This is unbelievable to the Southeast region staff, to all the EMS providers, to Dr. Suggs, to all the hospitals, to Dr. Campbell, to Dr. Williamson, who was willing to take the chance at this. And I don't know whether Dr. Williamson remembers when we had the initial meeting, and he said, there's just not enough money to do this. And we said, Dr. Williamson, give us a chance. We'll make it work. And so I think this is a real fantastic process for the public to recognize that the health department, all the hospitals, EMS providers can all work together. It doesn't always take all of that money. It takes a lot of social engineering, a lot of cooperation, a lot of education. But when you recognize that the administration rate of that drug that the physicians have talked about is now probably 3 to 4 times what the national average is, especially for this kind of rural population, you recognize the tremendous benefit to you in the public in this area, and you recognize that this is a program that didn't cost a fantastic amount of money because Dr. Williamson, in his wisdom, said, let's task the existing process and let's expand it out. That means for very little funds, we actually are returning a tremendous volume of people back to the workforce. Their quality of care, a stroke is no longer an issue that death is here, death is imminent. It is now a chance for basically revival of those patients because of what Dr. Suggs does, what this system does, and what you will do if you recognize the stroke signs and symptoms that Dr. Knopfsinger talked about and get to the hospital quick via 911. The other beauty of this is it doesn't require that hospital to be available 24 hours a day, 7 days a week, so it doesn't cost them a lot of money. So again, what Dr. Williamson's looked at here is the issue that the hospitals are in charge. They're not forced to do anything. It's voluntary. But look what happens when everybody works together. Unbelievable for you and the public.
Thanks, Joe. Yeah, let me just, before we do questions, what I think the most important take-home for this is, number one, for individuals who have the sudden onset of symptoms, whether those are unilateral, one-sided weakness, whether it's difficulty speaking, whether it's a vision change, whether it's something as subtle as the acute onset of dizziness unrelated to a change in posture, calling 911, getting plugged into the stroke system, then getting routed to a facility that can manage your stroke is maybe the difference between returning to full function or being left with permanent disability. It may be in some cases the result between surviving and not surviving. So this makes a huge difference on an individual and personal level. And let me say, follow up on what Mr. Acker said a minute ago. This isn't because the state of Alabama put hundreds of thousands and millions of dollars into the system. We've run this using, number one, the infrastructure that was already there, put together for our trauma system. And on top of that, just like the trauma system is a voluntary system that's been run with no dollars available for hospitals and physicians to do this, the stroke system that we've been building is also a voluntary system. Now, we do need to go statewide. That's our goal, is to go statewide. But we think it's important to demonstrate that we've made a difference in one part of the state. The only thing we have it to compare with is the Birmingham region, which you've heard has been running for 14 years. We're doing well. There's obviously more we can do. We look forward to expanding this into other parts of the state. But for a disease that is so important in Alabama, a state where we have such problems with cardiovascular disease, cerebrovascular disease, such a problem with stroke and hypertension, being able to reduce morbidity and save lives through a voluntary cooperative system involving the doctors, the hospitals, and the emergency medical systems of the state, it's a wonderful step forward for the state. So let me stop there, and I'll be glad to answer questions.
Dr. Williamson, why start this system in the southeastern part of the state where you're seeing a higher incidence of stroke in that part of the state, or?
You know, when you start a voluntary system, the most important thing in starting a voluntary system is having people who want to make it work. And Dr. Suggs was a champion for starting this. So when you have someone who is a champion for starting it, when you have them in the southeast part of the state, when you then have the hospitals in the southeast part of the state wanting to come on board to start the system, it's always easier to start a voluntary system where people want it to work, so we started it here. I can't tell you that we have more strokes here. I can tell you we had a commitment here to make it work, and now based on that, I look forward to seeing this commitment spread statewide.
Thank you.
Other questions? Well, if not, thank you all very, very much for taking your time, and I hope to come back to you in another few months to talk about how we've gone into other parts of the state. Thanks very much.